Dallas time. I'm the Chief of Cardiology at Dallas VA Medical Center, and PAD and peripheral artery disease is my area of interest, and I think out of Dallas and Southwestern we lead the XLPAD registry, which I'm very delighted for each one of you to be able to participate, and for those who have not and have not participated in our studies and registries, I invite you to log in to www.xlpad.org. So the topic of today's discussion is antiplatelet therapy following peripheral artery revascularization. This is a slight departure from our regular webcasts, which are mainly case-based. I think the reason we are moving into more didactic topics is because there's been a request from many participants in the past to at least make one or two didactic topics a month, and the remaining two are also expert case-based presentations. So please stay tuned. I also apologize for not scheduling this webcast on the first Thursday of every month. This is the second Thursday, and I think from next month we will be sharp on the first Thursday of the month. So those are some of the organizational aspects. Let's get into the presentation. This topic is quite difficult because there is not which is randomized. However, I've tried to lay it out as best as possible, and if there are any thoughts and comments either during the presentation or after the presentation, you feel free to punch in and speak up, and I don't mind being interrupted. Also, I have one additional request. Please mute your lines. If you would like to ask a question, just unmute the line and please speak up, but otherwise, please keep your lines muted if possible. So let's get started. I think we all know that patients with peripheral artery disease are at a higher risk for major adverse cardiovascular events, abbreviated as MACE, and major adverse limb events. For those not male might feel prejudiced, but I think this is a cute abbreviation recently being adopted. It's called MALE or male. And antiplatelet agents are prescribed to patients with peripheral artery disease for reducing and tackling both the heightened risk of MACE and limb events or male. So today's focus is quite narrow, and I have just highlighted 4 points based upon which I've selected the studies today. First, I have selected studies that really address contemporary antiplatelet agents that are used in our practice today. Number 2, I've tried as best as possible to remain focused on level 1 or level A evidence or randomized clinical studies. Number 3 is that I've tried to take on studies which are relevant to endovascular interventions today, the way we practice it. And finally, I've stressed on more recently published data and tried to stay away from historical evidence, though that is equally important. But given the scope of our presentation, I think it will be quite difficult to tackle each and every study that each one of us have been familiar with. So with that prelude, let's get right into the data. To organize our conversation today, I tried to present to you this very simple scheme. Patients with peripheral artery disease who undergo endovascular interventions have, as I have suggested, have 2 kinds of adverse events, cardiovascular and limb events. And the studies that I will be focusing on are those who address each one of these. The first broad category are patients who are initially asymptomatic and have asymptomatic PAD and their peripheral artery disease has been detected based upon an abnormal ABI finding primarily. There are the second group, the bigger group for today's discussion are patients who have symptomatic peripheral artery disease, and then they have been referred to treated either conservatively with exercise therapy or medical therapy, or those who are in addition to being referred for some sort of revascularization procedure. And those procedures can be divided into 2 groups, endovascular and surgical. So that would be the scheme of our talk, and I think the evidence I will be presenting would be relevant to each of these sections. The first section that I want to address today is not the main focus of our conversation because it is primarily directed towards patients with endovascular intervention or some sort of revascularization procedure. However, historically and because this is such an important study, which the POPAD study, because it for the first time selected patients with two risk factors. One is diabetes and the second is smoking, and the largest cohort in that study were diabetics with an abnormal ABI defined at an ABI less than 0.9. And so this, I would view, if you are familiar with cardiovascular prevention studies, this would be a kind of secondary prevention, patients who have established PAD based upon an abnormal risk factor and an abnormal ABI in addition to it. These patients, about 1,276 patients, were randomized to aspirin monotherapy and compared to placebo. The dose of aspirin was quite variable, but the mean dose was closer to 160 milligrams. The follow-up was fairly long, as you can see, 6-year follow-up. And I've divided the outcomes into two parts. In terms of cardiovascular death or stroke, the aspirin group had 6.7% patients met the primary endpoint of the study, which was cardiovascular death or stroke, compared to 5.5%, as you can see. The hazard rate is 1.23, and the confidence intervals overlap unity. So it did not show any benefit, at least in this sample size, within this sample size, that in treating patients who are asymptomatic with an abnormal ABI, even with the risk factor of diabetes, there would be a significant reduction in cardiovascular endpoints. In terms of amputation, it was above the ankle amputations only, and these were unplanned amputations. And again, as you can see, there was no difference. So at least for this is just one large study. There are many other observational data regarding treatment of patients with asymptomatic PAD detected purely based upon an abnormal ABI study, but this is probably the most significant one. So the conclusion for this section is that aspirin therapy for secondary prevention of patients with asymptomatic peripheral artery disease and diabetes did not show any benefit. Let's move on to where the bread and butter patients that present to us with symptoms, and many of these patients are treated with intensive medical therapy, and because the focus is today on antiplatelet agents, I have selected clinical trials that routinely focus in that area. So this is a study which kind of is an overlap between asymptomatic and symptomatic patients, and I've highlighted this is called the CLIPS trial. This was a 366 patient study. This was published in 2007. It had 2-year follow-up, and the reason I highlight that in this study, though most of the patients had claudication symptoms, about a fourth of the patients were asymptomatic, and again, they were randomized to aspirin monotherapy and placebo. In terms of cardiovascular events or major adverse cardiovascular events, which included cardiovascular death, non-fatal myocardial infarction, and stroke with a 2-year follow-up, there was a significant reduction of MACE events at 2 years with aspirin therapy. I think this study is widely quoted in most of the PAD guideline documents, amongst others, which I will review in a few minutes. The second outcome of the study was a composite of cardiovascular events and presentation or treatment for critical limb ischemia. It was a pretty broad composite outcome. However, as you can see, 6.49% versus 15.5% compared to aspirin versus placebo respectively, with a significant p-value again suggesting a lower number of secondary endpoint, which was cardiovascular death and presentation with CLI. So this was one of the early studies that showed that predominantly symptomatic patients could be benefited with some sort of antiplatelet therapy, which in this case was only aspirin. The two other studies that I want to cite here are not directly PAD studies, but they included patients with peripheral artery disease, and I think it's worth mentioning because most guideline documents do refer to these studies. And secondly is because they are relevant to our practice because they have for the first time introduced the use of clopidogrel or clopidogrel outcome data in patients with peripheral artery disease. So CAPRI, most of you are very familiar with, is a 6,500 approximately patient study with with 2 years of follow-up with the primary endpoint again of cardiovascular death, non-fatal MI or stroke for this particular subgroup of patients. Again, there was a statistically significant reduction in major adverse cardiovascular events with clopidogrel compared to aspirin therapy. I do mention, though, there were no pre-specified PAD-specific outcomes in the study, but the investigators did report non-significant reduction in the number of cases of CLI referred for amputation in the paper. This is from Lancet 1996. And more importantly, there were more intracranial bleed, about 2.3% in the clopidogrel arm compared to aspirin, which was closer to 1.7%. So this was some early evidence where antiplatelet therapy outcomes was published and reported for patients with peripheral artery disease. Again, this was not a dedicated endovascular intervention study. Just want to clarify that. The third study in this along the same theme is Charisma. Again, I'm presenting to you the peripheral artery disease subset of patients, about 3,000 patients, 26 months of follow-up, dual therapy with clopidogrel and aspirin versus aspirin alone, with the primary endpoint of cardiovascular death, again, non-fatal MI and stroke, which showed a non-statistically significant reduction with dual antiplatelet therapy, again, in a predominantly PAD subgroup of this large cohort of patients treated with clopidogrel and aspirin. In terms of hospitalization for ischemic events, I think it needs to be clarified that this particular data point has been highlighted quite frequently in many review articles, but I think it was a composite endpoint which was not purely based upon limb events, but did include lower extremity revascularization events. So this is a composite of both cardiovascular ischemic events, hospitalization for cardiovascular ischemic events, and lower extremity revascularization. So it is not purely limb-based events. And again, this composite endpoint did show a reduction. I apologize for the typo. However, there were more minor bleedings in the dual antiplatelet therapy group. So the conclusion from these three studies are that if you take patients with symptoms and who have had some sort of prior peripheral artery intervention in the past, historically, those patients, if they are treated with dual antiplatelet therapy, we at least see some signal of reduction in not only cardiovascular endpoints as in the CLIPS trial, but also in terms of reduction in lower extremity events as indicated in this composite endpoints of these three studies. The most recent addition to this database is the TRA2P study. This is a new drug. It's called Vorapaxar. This is not the forum to go in depth into it. However, worth mentioning that this drug purely blocks the PAR1 receptor. And again, the PAR1 receptor is a receptor on thrombin, which prevents the interaction of platelets with thrombin, and by blocking this particular thrombin receptor, we can completely eliminate thrombin-mediated platelet aggregation. Again, this is a PAR1 selective receptor antagonist. And in this study, this is a large study which actually included over 24,000 patients, but this is a peripheral artery disease subgroup of that particular study. And the reason this study is worth mentioning is reasons. One, that there was a very strict definition of patients with PAD that could be included. These had to be patients with symptomatic PAD who have also had, which either had also undergone lower extremity revascularization. So they either had to have symptomatic PAD on some sort of medical therapy, or had to have some sort of prior revascularization procedures, both endovascular and surgical were allowed. As you can see, that Vorapaxar was an add-on third agent to aspirin and clopidogrel in the active arm, and the placebo arm had only aspirin and clopidogrel. So the significance of this study is that this was an additional PAR1 receptor antagonist added on to aspirin plus clopidogrel, and compared to dual therapy alone. And as you can see, in the dual therapy arm, in the active arm, overall 37% of patients received both aspirin and clopidogrel. So I think this gives us some insight into what we can anticipate with intensification of blockade of thrombin platelet-mediated platelet aggregation. In terms of the composite endpoint, which was for the entire study, cardiovascular death, MI, or stroke, there was no reduction overall. However, we could argue that this was an underpowered, pre-specified sample of patients. However, in the overall study, it was no different at all. In terms of limb ischemic events, and these are two very important points, that this study did specify two pre-specified outcomes which were dedicated to studying outcomes of patients with peripheral artery disease. It had one endpoint called limb ischemia, and the second was need for peripheral artery revascularization, both surgical and endovascular. As you can see, for the very first time, both these events were significantly reduced, and I think that this created a significant buzz in the PAD area, and I think it also suggests that blocking the interaction between thrombin, which is such a potent, or probably the most potent stimulus for aggregation of platelets, could be beneficial, especially in patients with peripheral artery disease. I can also historically suggest that similar studies with addition of warfarin in patients with peripheral artery disease in the past have not shown to be very effective. So this is right hot of the press. This was late-breaking clinical trial presentation at AHA in Dallas in 2012. So let's move on now to the section of patients who undergo some sort of revascularization. And I have split it up into two parts. I'll share with you some data on patients who have undergone endovascular and then surgical interventions. Because we have used 15 minutes of this presentation, I just want to stop here and ask if there are any questions or comments on these on the first two sections while I move to the remaining two sections, which are probably of primary interest to us as interventionalists. So if there are any, please feel free to interrupt me and ask those and share your comments. Otherwise, I'll keep probably moving along. So in terms of endovascular intervention, this is historically, and this is a very important study because this was the first evidence of use of aspirin therapy, first study or first attempt to study aspirin use in patients with endovascular intervention. This was published in 1990. The study and this outcome analysis was done in the late 80s. And this was a small analysis of 216 patients who were randomly assigned to high dose versus low dose aspirin with a 2-year follow-up after femoral popliteal revascularization for patients presenting selectively with restenosis after prior angioplasty. There was no stenting those days in the infrainguinal arteries. The 2-year patency rates, so this is not clinical patency, this is actually duplex patency, was not statistically significant. However, there was more GI discomfort as expected and some non-major bleeding with the high-dose aspirin. But however, historically, this was the first attempt towards studying antiplatelet drugs in PAD interventions. The mirror trial was the next attempt, as you can see, about 12 years later, or this was the next attempt. And this was a study out of Germany done by Gunnar Teppe's group and Thomas Zeller's group in Leipzig, in Bad Krozingen in Germany. As you can see, this was a randomized study, and it randomized patients to dual antiplatelet therapy after endovascular intervention, primarily in the femoral popliteal area, and included both angioplasty and stenting. However, there were more patients who underwent angioplasty. The dose of aspirin was very high, and it was compared, and clopidogrel and aspirin were compared to aspirin monotherapy. The primary endpoint of the study was 6 months clinical need for target lesion revascularization. As you can see, the investigator reported a significant difference in that outcome, and it was statistically significant, and it was reported in the European Journal of Radiology. Strangely enough, outside the primary endpoint of the study, they continued to follow these patients up to 1 year, and again, the initial benefit seen in the dual antiplatelet therapy arm completely vanished, which was quite perplexing. And similarly, there was no significant difference in the 6 months cardiovascular events. So a mixed bag of results, not much we can hang our hats on. Again, historically, it did show that at least in the short term, dual antiplatelet therapy after femoropopliteal interventions might be beneficial. The next section of this presentation, I have tried to put a lot of this data into some very simplified tables, and I have tried to group them based upon therapy, type of or modality of endovascular therapy. If you follow me from the top, I am going to show you or present to you some atherectomy trials. These are two major studies that have been published both in 2011 and 2013. Importantly, they were both in the femoropopliteal area with atherectomy, and these were all Silver Hawk and Turbo Hawk atherectomy patients. The first study, which was published in 2011, used a single-arm study showing the effect of studying the effect of aspirin and clopidogrel for 4 weeks after atherectomy, and reported a 12-month primary patency rate of 69%. So these are not comparative studies, but at least studies that have mandated or required some sort of dual antiplatelet therapy. The second study is actually more of a angiographic study in terms of studying late loss or neointimal hyperplasia in patients who had atherectomy in prior braced stents or in-stent restenosis, studying the need for reobstruction, and the primary endpoint of the study was 6 months intimal thickness, as you can see, compared to 3-month DAPT versus no DAPT, only aspirin monotherapy. There was a statistically significant reduction in intimal hyperplasia. So I think this is interesting. I can't really tell you how aspirin or clopidogrel therapy, simply dual antiplatelet therapy, directly affects neointimal hyperplasia. I think this could be potentially through a reduction in some inflammatory pathways. However, these results are interesting and did, at least in the short term, suggest some finite difference between the two studies. The other two studies, the one from our group, the COBRA study, which also studied a post-dilation of nitinol self-expanding stents with either conventional or cryoplasty balloon, did require a 30-day minimum antiplatelet therapy with a 300 milligram load. So these two studies, the COBRA and the COLD studies, were studies that simulated or emulated coronary interventions, requiring a loading dose of clopidogrel pre-procedure and then following it up with at least 30 days of dual antiplatelet therapy. As you can see, there was a reduction in the binary stenosis in the COBRA and a 9-month and a trend towards a 9-month reduction in target lesion patency with the dual antiplatelet therapy. However, in the COLD study, the results were not statistically significant. But these were studies which are also important because they required a mandated regimen with a loading dose of clopidogrel. There are lots of studies in the bare metal stent arena. I have listed them on this slide. Of interest, I've grouped them also based upon the area of intervention. As you can see, the top two studies, the COBEST and the outcome of the bare versus covered stent in the iliac arteries are iliac studies. They're all published in 2011 and 2014 and compared aspirin and clopidogrel 4 weeks for the COBEST trial after a loading dose and 6 weeks for the second study in the iliac intervention area. As you can see, the 18-month, the primary endpoint for the COBEST trial was the 18-month freedom from binary stenosis with the covered stent, which did show a lowered restenosis rate with the covered stent with at least 4 weeks of dual antiplatelet therapy. I also want to emphasize that if you look at the literature, contrary to common belief, most clopidogrel use has been in the iliac interventions, and there are select trials in the SFA and infrainguinal area, though we anticipate more benefit in that area. So there is more work that needs to be done for femoropopliteal interventions, as I'll state as we move along this presentation. The remaining 3 studies are quite recent studies that are very well known. These are compared angioplasty to stenting have led to the adoption of 19-ol self-expanding stents in the femoral popliteal area. And the resilience study included the angioplasty versus stenting. The Absolute, of course, published in 2007, also mandated aspirin and clopidogrel like the Resilient for 12 weeks after a clopidogrel load. And the FAST study was angioplasty and stenting, which only required at least required a 4-week dual antiplatelet therapy. Again, the outcomes of these studies are shown on the extreme right panel. There was a statistically significant reduction in binary restenosis at 12 months with Resilient and 2 years with Absolute, with no significant difference in the FAST study. I just want to get back to this slide and say that there was another study called FACT, F-A-C-T, not F-A-S-T, which built on the results of the FAST study, and that included the patients randomized in the FAST study and added on additional patients and looked at 2-year outcomes, and that did show a lower need for target lesion revascularization with 4 weeks of dual antiplatelet therapy, but with an extended duration of follow-up. Just want to mention that. There is great interest in looking at the requirements for dual antiplatelet therapy for drug-coated stents and drug-coated balloons. And I think we have a major publication accepted in JACC Interventions, and I think you should see it soon in press. The primary author for the paper is Karan Sarode, and that paper also kind of highlights the table that I've shown here. All the drug-coated balloon studies, Levant, Thunder, Pacifar, Impact, Debate SFA, and Debate BTK. Most of these studies have been in the SFA and femoral popliteal area. There is one randomized study which is in the BTK, in the below the knee intervention, which is the Debate BTK study. And I won't go over all of the results of this study. I think it is quite clear that drug-coated balloons in at least mean or intermediate lesion length do show both improvement in clinical patency, reduction in restenosis, and also lowered late loss in terms of reduction in new intimal hyperplasia. The duration of antiplatelet therapy, quite interestingly, has been extended in most of these studies from the routine 4 to 6 weeks, as you have seen in the bare metal stent and the angioplasty studies in the past, in the prior slides, to 12 weeks. So we do see an extension in the duration of antiplatelet duration in drug-coated balloon studies. Let me go quickly and state what's happening in the drug-coated stent area. While I show you this slide, you can peruse and look through it. I just want to make one very important comment that the Zilver PTX study, which is the 4th on the list, which was initially published in Circulation in 2012 and then extended publication in 2013, was the first study which its IFU or instruction for use actually came with a recommended duration of dual antiplatelet therapy. So if you read the IFU for the Zilver PTX paclitaxel coated stent, it did require or mandate a 2-month duration of dual antiplatelet therapy. However, 72% of patients received 3 months or more. So most operators opted for longer duration of dual antiplatelet therapy. Of course, there was a significant reduction in the need for target lesion revascularization, as shown in the 2-year patency rates, 74.8% with the Zilver PTX in the Zilver PTX arm compared to the comparator arm, 26.5%. Again, want to mention that an important criticism of this trial was it was not truly a drug-coated versus bare metal stent comparative study. It was more of a angioplasty, a provisional stenting study as a primary randomization and a secondary randomization for patients who failed angioplasty to drug-coated stent and bare metal stent. So, however, it doesn't diminish the importance of this study. And again, along other studies that I've mentioned, Scirocco, Achilles, and Destiny, there is a trend towards extended duration of dual antiplatelet therapy with drug-coated stents at least in the femoral popliteal and below the knee arena. So I think these studies are of great importance, and I'm sure we're going to see more data in this area. To simplify and put this all into perspective, I've tried to create a trend of dual antiplatelet therapy durations over the years. In blue are a composite of atherectomy studies. As you can see, in general, 3 months has been the recommended duration of most studies. And this is not just the studies I've shown here, but every study that has been published. I've kind of taken a mean of those studies. If you look at simple angioplasty studies, either it is traditional conventional balloon or cryoplastic balloon or other specialty balloons, most have been in the area of 2 months to 1 month. And again, there's no particular trend that you can see in terms of angioplasty studies. However, for bare metal stent studies, between 2007, 2009, and 2010, there has been a slow progression towards longer duration initially for 1 month and now towards 3-month duration. And for drug-coated stents in green, as you can see, again, there is a clear trend towards from 2006 to 2012 for extended duration. And I think the most recent studies have included 1 year in the pacifier, 1 year in Levant, 1 year of antiplatelet agents. And finally, drug-coated stent studies, which do strongly suggest that we are moving towards extended durations, at least 3 months. As I mentioned, this is mandated or required duration. As I mentioned, 72% of patients in the Silver PTX use more than 3 months of dual antiplatelet therapy. So I personally believe there is a trend towards increasing use of these agents, at least in endovascular interventions. A last word in the remaining few minutes. I have about a minute and a half for patients who undergo surgical revascularization. And this is a composite table which lists 4 or 5 major studies of below-the-knee and femoropopliteal surgical revascularization. And I think there is more randomized level 1A evidence for patients using dual antiplatelet therapy after surgical interventions. As you can see, the most important of this study are 2. Number 1, basal, which was a critical limb ischemia patient study, which did not require any dual antiplatelet therapy, however, did not show any benefit. And in contrary to that, the randomized trial published in the Annals of Surgery, this is a randomized controlled trial of DAPT in patients undergoing surgery for critical limb ischemia. Of course, a smaller study than basal, and did require at least 3 days of aspirin and clopidogrel dual prior to the procedure, and then aspirin monotherapy following surgery. And in that study, both clinical and a biomarker endpoints were met. I think, and it did show that there was less platelet monocyte aggregation, leading to lower need for revision of the graft over 1 year. The most important study that one needs to know about surgical intervention is the CASPAR study. I think this is a 6-month versus 24-month randomized study of 400 patients comparing aspirin plus clopidogrel to aspirin monotherapy with the primary endpoint of graft occlusion and revascularization and amputation above the ankle, again showing no effect of shorter versus longer duration of dual antiplatelet therapy. I think this study is important because we have kind of paid great attention to this study, and we can hypothesize or postulate, and a lot of editorials have been published. Maybe the 6 months and 24 months were not enough duration, or the study was also could be underpowered for such an outcome. So we ourselves presented our data. Swagata Das, one of our research coordinators and fellows, did present this data at SCAI. And this is our analysis from the XLPAD registry of 494 procedures in 367 patients. And we grouped them into less than 3 months and greater than 3 months. As you can see, this was not a prospective study. Of course, this is a retrospective analysis from the database. But the most important part is, as you can see in yellow, that at least half of the operators chose to put their patients for less than 3 months, and half of the operators chose greater than 3 months, suggesting the equipoise in this area and need for more evidence. Skipping through to the primary analysis, as you can see, in terms of composite endpoints, including both cardiovascular and limb events, there was absolutely no difference between the 2 durations. And I do suggest that these studies, including the evidence that I presented today, raise the need for a dedicated, prospective, randomized controlled trial in this area of PAD interventions. So to conclude, antiplatelet agents are prescribed to reduce both MACE and male events. Dual antiplatelet therapy is increasingly prescribed in clinical practice and required and mandated in new peripheral artery interventional trials. And finally, I think there's a trend definitely towards extended duration in at least for this presentation, if the word extended stands for greater than or equal to 3 months of DAPT. And I think there's also a trend towards more intensification of this therapy with newer agents like Varapactor and rivaroxaban and other drug combinations and ticagrelor, like in the Euclid trial, which are going to emerge in the PAD area. And I think there is great need for carefully designed, well-powered antiplatelet therapy selection and duration trials. I'm going to end here and just leave you with one slide. This is from the ASPIRE study. This is Antiplatelet Strategies for Peripheral Artery Interventions for Revascularization of Lower Extremities. This is a new study we are starting. It will randomize 200 patients in each arm after iliac, femoral popliteal, and below the knee intervention, randomizing patients to either 1 month of dual antiplatelet therapy compared to 1 year. And the difference between this and the CASPAR study is the composite endpoints includes both cardiovascular endpoints and limb events. So the primary objective is to evaluate whether clopidogrel 75 milligrams daily on a background therapy of aspirin for 12 months or for 1 month will lead to an increased rate of primary patency, limb salvage, non-fatal myocardial infarction, ischemic stroke, survival in patients receiving endovascular treatment of PAD at 1 year. So I encourage, if you have interest, to call on us or log into the XLPAD.org website and get further information and instructions. So I'll end here. Please unmute your lines. If there are any comments or questions, I'll be happy to take them. And so please don't be shy and chime in with your comments and suggestions and questions regarding this presentation and otherwise how you practice use antiplatelet therapy in your own practice. So please take it away. Very good. I think there is, if there are no comments and questions, I think I just have one final comment from my side is that we would be very interested that we are actively recruiting for sites who would like to participate in the ASPIRE study. I think this area is an intensely growing area for research and investigation. And if you have any interest and comments, call us or email us.
Hey, Dr. Banerjee?
Please.
Hey, Ian Cowett here from Arkansas Heart. Is there any data on the use of warfarin or Xarelto? I know some physicians will do that.
I can tell you that the use of warfarin has been studied in surgical graft patency studies, and there has been absolutely no difference in comparing artificial grafts to venous grafts and using warfarin as a drug in addition to aspirin. I am not familiar with a study which is dedicatedly studying the use of rivaroxaban or other agents in that class after endovascular interventions. I am familiar with the Euclid study, which is studying ticagrelor as an agent and comparing it to clopidogrel in patients with peripheral artery disease, but it is not a dedicated peripheral artery intervention study. It is patients looking at secondary prevention of both cardiovascular and limb events in patients with established PAD. It's a wide definition. It includes patients with abnormal ABI symptoms and with prior history of prior revascularization, but it is not a dedicated endovascular intervention study. So the ASPIRE study is one that I think is going to be the first that will study the duration, the effect of duration dedicated to iliac, femoral popliteal, and below the knee interventions. So my question back to you is that how do you decide in your clinical practice? I know you guys do probably one of the highest volume of peripheral interventions in the country. So how do you decide between when you treat, and does the modality of treatment affect your judgment in terms of selection of antiplatelet therapy?
I think we definitely look at the comorbidities with the cardiovascular risk factors. But for most of my practice, I do use Plavix for 3 months duration, using the dual antiplatelet therapy strategy of aspirin and Plavix.
I see. That's very interesting. I'm very interested in your selection of 3 months. I think, as you can see, most evidence points to it. But I think I just want to mention that there is a big debate. The TAS guidelines suggest the use of any antiplatelet therapy, and the ACC/AHA guideline, the ESC guidelines, suggest use of aspirin only post-interventions and do not make a definite recommendation for dual antiplatelet therapy at this point. There is no recommendation for duration. They do suggest a minimum of 30 days. So I think that this study might be of interest, and I think if it is, I would definitely like to have your participation.
Absolutely. We'll most definitely be looking forward to it. Thank you, Dr. Banerjee.
Thank you very much. If there are no additional comments, we're going to end this here, and we look forward for you all to chime in again on the first Thursday of next month. I greatly appreciate each one of you participating in the webcast, and if you have any suggestions for topics that you would like to share or are interested in, please let us know. And if you have an interesting case or interesting topic you want to share on the XLPAD forum, you're invited to email me and reach out to me directly. Thank you again, and have a pleasant day, and get back to your work and businesses. Bye-bye.